out there that knows the answer. And if we try to do things in a siloed approach, we're going to break it. Because if I touch something over here, something down there is going to break. And that's what we're seeing right now, is the unintended consequences of a COVID pandemic. And none of us had a run up to COVID to kind of practice. We did our best. We're nervous about the fall. We know COVID is still out there. We're predicting a really bad influenza season. Pressure's on the hospital already. We have to work together. We have to anticipate. We need to be smart. Saying to Albertans out there, it's still real. You know, wash your hands. Masks do work, whether you want to wear them or not. And just, you know, stay home if you're sick. But be respectful if you do have to come into the hospital-based system this fall or into your family physician's office, so that they're doing the best they can, right? And we are working forward, but there are no immediate fixes. And these are solutions that, as we put them in, will start rolling forward, but it's going to take time.
Thanks. Tim, do you have a follow-up?
Yes, I do. You mentioned COVID there, and that you're nervous about the autumn. You know, obviously the new numbers show hospitalizations, case numbers are up. Are there any plans here to boost or alter the system before a potential autumn wave? I mean, will things look any different in the coming months because of the pandemic?
Yeah, so there are plans in place. Like at the first step, really, and we've already rolled out the new bivalent vaccine. So, you know, urging all Albertans who, if they haven't got their booster in the last 5 weeks, last 5 months, to actually go out and get that for what you're eligible for. In addition, go get your flu shot. So we're actually going to be a campaign we'll be starting in the next couple of weeks to do that, because it is actually going to be a bad flu season. So that's the first line of defense. AHS is putting in together plans to actually increase capacity, particularly in areas where there's there's stress already. Fortunately, we saw some of the pressure come off the system from last spring in hospitals generally around the province, but not necessarily in Calgary and Edmonton, where there's increased strain on the hospital. So AHS is working through their plan to add further capacity into the hospitals, and this is part of our overall approach as a government. We're spending $22 billion on the expense side this year, the highest ever in the province. That was a $600 million lift this year, a $600 million lift next year, a $600 million the year after that. So we are investing to build capacity in the system to be able to respond to the demands. But then there's no quick fixes, there's no easy fixes, and that's why this agreement is so important, because it actually provides the base for an ongoing partnership with doctors, so we can work together to solve these challenges.
Thank you, operator. Can you put through the next caller?
Janet Price, CBC.
Hi there. First question is for Minister Copping. I've heard from some family doctors who do not like this agreement. They say that the increases do not keep up with the costs of inflation that they're going to be experiencing in their businesses, so they'll actually lose money, and that the investment in rural recruitment and retention strategies is a pittance compared to the size of investment actually needed to make a difference. What makes you so confident that this agreement is enough to keep family doctors working in Alberta?
Yeah. So, well, thanks for the question. So this is, we heard loud and clear from the AMA and working through these issues that we needed actually targeted money, and we actually see that in the agreement where additional funds. It's not a straight one number across all of the sections, but we're actually targeting more money for family practices and that are in need. And the other key point I like to make is not only are we targeting money in this in rural areas, but quite frankly, this is the first step. It's in the conversations that we're having about the announcement we made last week on primary rural and Indigenous care, and the task force is looking at, okay, what else do we need to do? Part of this is also looking at different approaches. So it's not only about the amount of money, but how are we spending that money? Are there different models that doctors' family practices can use, which actually would ensure not only viability, but result in better care? So for example, a blended capitation model, what I know that some doctors are looking at. But we need to do this in concert with the AMA and with doctors, be able to roll that out, explain that there are other options to support family family practices, and then how do we accelerate that? So, this agreement provides a basis for those conversations. The primary care initiative, which the AMA is also involved on the steering committee, will provide more opportunities for other ways that we can do things, because we know, this agreement won't solve all the problems, but it's a big step forward, not only in providing an initial infusion of cash to stabilize, but also looking at how do we use our programs better. Like, so for example, we're spending already $90 million for on rural physicians to be able for retention and attraction across the province. This agreement also provides opportunities for us to how do we look at that better and target that better, in different areas that we can put it in. So the reason why I'm so confident is because this is a partnership. It's ongoing communication. It provides us tools to be able to look at different approaches that we can use to support family practice and community practices, and then we're going to make changes as we go forward.
Thank you, Janet. Do you have a follow-up?
Yep, this is for Dr. Warren. So we're going to have a new premier within a couple of weeks, and possibly a government with different priorities, different agenda, and yet this agreement contains this political promise to repeal the legislation allowing the government to unilaterally rip up any agreement with the AMA. So in your mind, what is an acceptable timeline for the Alberta government to pass that bill, and what would prompt you to terminate the lawsuit?
All right, so thanks very much. The members were very clear that the lawsuit is to stay in play until the legislation is successfully repealed. And so that's actually within this agreement. In terms of what's an acceptable timeline, I think legislature has to come in first. And I'm not a political scientist nor a minister. So as soon as possible, I think, would be the answer that I can give, because that's what members are looking for. Trust is something that is easily broken and is hard to rebuild. And for a lot of physicians out there, it's the actions that have been taken this year. It's the actions going forward into the future that really is going to begin rebuilding that trust. This agreement is with the government of Alberta, and it's the Ministry of Health together with the Alberta Medical Association. The premier will be different after the leadership vote. There's an election next spring. It doesn't matter. Healthcare is healthcare, and patients need that care no matter who is running the boat. And I think my plea to politicians everywhere is stability is necessary to begin rebuilding and healing and making change. And introduction of more chaos is not helpful. So I would love it if healthcare was outside of politics completely, so we could focus on what we need to do. Our reality is it's not. It is tied into election cycles. So be cognizant that we as physicians need stability to do our jobs. And nurses need stability. Hospitals need to be there so we can move forward and do the things that we need to do in our day-to-day lives. And that additional instability is not helpful. So getting the legislation repealed as soon as possible will be great, and only once that happens does the lawsuit discontinue.
Thank you, operator. Can you put through the next caller?
Brianna Carson-Smith, Global News.
Hi, my question is for the minister. You were talking about AHS expanding capacity as we get into a difficult flu season and increase in COVID cases. Can you speak to more what that will look like? Are we going to see more of these overflow rooms? What about staffing? Any details you can provide?
Yeah. So we have been, expanding capacity across our entire system. And just to recognize that when we talk about our acute care system, it's a pipeline. So it's not only, like the first step in that pipeline often is EMS, then it's the emergency departments, inpatient beds, and then we need to do placement often into continuing care or different levels of care. And so, part of our $600 million is increasing capacity in each of those spaces. So, additional $64 million for EMS, plus we're doing a number of reviews right now, and I just received this week the APEC, the advisory committee on EMS, their final report, and looking at changes of how we can change processes within our system to actually reduce the times. We've invested $100 million into increasing 50 ICU beds, and all of those will be staffed and available for use by the end of this month. But just to be clear, it's ICU if necessary, not necessarily ICU. We want to make sure that we have that for surge capacity, whatever COVID or other health issue is going to throw at us. But if we don't need the staff in the ICU. We need them on inpatient beds to do that. And then on the continuing care side, we're building 1,500 additional beds across the province, and then we, as part of Budget 22, additional $200 million for capital for over the next 3 years. For beds on top of that, and we've just recently put on an RFP for renovations and renewals of beds across the province. Plus, AHS is working with docs, and quite frankly, conversations with the AMA docs. About, okay, how do we change our processes within our emergency departments to actually streamline the ability of people coming in, getting into inpatient, and then out the door to continuing care. So all that work is being done. We have more staff than ever we've had, in terms of nurses, in terms of doctors, and we are continuing to hire. I've been traveling the province, talking to AHS employees and healthcare workers, and also external stakeholders, including mayors and people working in continuing care and advisory committees. And part of that process is as well as identifying, okay, these are the challenges that we're facing. Here's what we're doing. What else can we do to solve this? And we're getting fantastic input, and we'll be bringing forward the results of that over the next coming weeks.
Thanks. Do you have a follow-up?
I do. I'm wondering, it's 980 people in hospital, 40 in ICU. We've really seen the tone of messaging around COVID change. When the first shots were available, there were emails, there were billboards, things like that. With the bivalent, there's been literally zero advertising to get your vaccination rather than, especially compared to what we were seeing early in the vaccination process. So I'm wondering what sort of responsibility you take in terms of the messaging and how that's played a role in the numbers that we're seeing right now.
I'm going to apologize. We have a really low, the volume sort of dropped off at the very end in terms of the question. Can you just sort of repeat the last part of it? And I heard the intro in regards to the approach to vaccines. Sorry, the last part of the question I just didn't hear.
Yeah, messaging in general has dropped off when it comes to COVID-19. There hasn't been the same sort of urgency from the province when it comes to getting vaccinated, staffing, things like that. I'm wondering what sort of responsibility you take with the numbers that we're seeing in hospital right now.
Yeah, so we continue to urge Albertans across the province to get whatever vaccine they're eligible for. We will also be, starting, not only our campaign for flu shots, but also urging people to not only get the flu shots, but the bivalent, at the same time, because that is still the best way to protect not only ourselves, but our healthcare system, and working with partners like the AMA to get that message out. So I would argue that we continue to push that. Now it's a choice of Albertans to get that to get the shot, but we continue to push that message that that is the best way to protect yourselves. These shots are safe. Actually, with the bivalent, they provide even greater protection because they deal with not only the original variant but the Omicron variant, and then asking people to get their flu shot to be able to protect themselves, their families, and quite frankly our healthcare system.
Thank you, operator. Can you put through the next caller?
Lisa Johnson, Edmonton Journal.
Hi, thanks for taking my question. This is for Dr. Warren. In the material we received this morning, the government noted that competitive compensation is important, saying that keeping Alberta physicians among the highest paid on average in Canada was a goal. How would you compare doctor pay in Alberta to other provinces, and specifically, what does this deal do to change that or that anyway?
Okay, so Alberta has a couple of things going for it when you are a physician working. Number one, what attracted physicians into Alberta in the years past, so prior to 2019, was a vision. It was a vision of something called the patient's medical home. It was a vision of every Albertan having a primary care physician working in a team to look not only at treating your illnesses as they arise, but also in prevention. And then part of what we call the medical neighborhood, where we had specialists working within that medical home helping care for patients. And it was groundbreaking. Alberta led the way with primary care networks. It was leading the way with alternative compensation, recognizing that patients that are complex with multiple medical conditions need more appointments, but they need a multidisciplinary approach to treat all of the components of their diseases and illnesses to make sure they have the best quality of life, and putting the patient at the center of that. And that's what attracted physicians in. Physicians are compensated well in Alberta, but like everywhere, they went through a period of time where there was no increases. Physicians are businessmen. They, particularly in the community, they run their own businesses out of the money that they bill to Alberta Health. They have to pay leases, salaries, all of that sort of thing, and pay for their medical equipment. And as all Albertans know, inflation has been rough, and physicians, just like the local restaurateur, are facing that. Unlike Tim Hortons, we have a single payer system, which means that when inflation goes up, I have to go to Minister Copping and say, hey, we need more money. And that's what this negotiation was about. The problem is looking at, is there a better way that we can now deal with the lack of physicians that we have? We have physicians who I would argue are very astute business people, because they are still practicing in their clinics despite having gone through a global pandemic. And as we all know, we've seen businesses close left, right, and center. Physicians are no different. We've seen closures. So this agreement is a beginning. It gives physicians an increase at a time when it's needed, but it also sets the stage for more. It sets the stage for us to sit down with all of the stakeholders to say, how can we do this better? Is there a better way to provide care to Albertans in a medical home, team-based care? How do we do that? How do we fund that? Do physicians want to work in one giant clinic, one smaller clinic? There's all sorts of things that need to be talked about. And that's really what this new primary care task force is going to be doing, is to look at these bigger issues and say, these problems were pre-existing, these problems are across Canada. Primary care has been struggling because you've got to be really smart as a primary care physician, because you're dealing with all ages from cradle to grave. And in the rural communities, you're in the community running your business, but then you're in the hospital looking after patients in the emergency room. And I'm a rural primary care physician and a business owner, so I totally get where this question's coming from. But the reality is physicians also want choice. And they need to be able to practice the way that meets their needs. And when I look at physicians, they're always there. They're always doing what they can do for their patients, but they're struggling. And so this agreement is the beginning of rebuilding relationships, but also trying to stabilize practices now so that we can answer those bigger questions going forward.
Thanks, Lisa. Do you have a follow-up?
Yeah, I have a follow-up for Minister Copping. Thank you. I'm wondering, Minister, the UCP has long argued that the province needed to rein in doctor pay, bring itself in line with other comparator provinces. So how does this deal represent a shift in the UCP's priorities or a continuation of those priorities? And how does it align exactly with the recommendations of the McKinnon panel?
This is, when you start talking about mutual gains bargaining, you look at everybody's interests, right? So we have joint common interests in terms of having viable practices, be able to, physicians who can actually provide the services to Albertans. And we know that we've had challenges, and this is even prior to COVID, particularly in rural areas, but since COVID, it's accelerated in terms of access primary to family physicians and primary care. And our objective is really, as a government, is we look at the costs that we put into the system, is how do we actually ensure that we bring in the cost of what we spend on doctors into line with other competitive provinces, right? So this agreement allows us time to jointly do that assessment and say where are the various and just to be clear, even though it's a single agreement over overall doctors, the reality is that different specialties and different sectors of doctors have different business models associated with that, and different rates associated with the fee for service models, and actually have different earnings. And there's even a recognition of this in the agreement in terms of dealing with internal equity issues. So saying we need to get more money to family physicians because that's quite frankly that's the workhorse. That is where we have the greatest shortages, and that's the bedrock of our healthcare system, and we need to get that working. So even when we've recognized in the conversation we need to shift some of the money there, we're going to do the assessment to make sure that our costs are competitive, and competitive goes both ways. It's competitive in terms of let's say if we're overpaying a certain area, then we'll drop that down, but if we're underpaying a certain area, that increases it up. But our objective as a government has been something we want competitive pay for doctors. We need doctors in our system. But we need to work jointly together to find solutions, because it's not all about just the amount we're paying. Are we getting the best value from that? And does it work for doctors? Like, I'm hearing from family physicians that some of them are spending far too much time in regards to red tape and which actually increase their ability to be able to perform services. And so how do we actually reduce that? What actually reduces their cost? Because really at the end of the day, it's after they get their revenue source from the government, what do they take home? And is that competitive they can do elsewhere? And actually, and it's not always just about the money. It's about the work-life balance. It's about, do I believe I'm contributing to a system that supports me? All these other pieces that Dr. Warren was talking about. And this agreement talks to some of that, plus the primary care initiative that we announced last week will focus on that more directly.
Thank you very much. Operator, could you put through the next caller?
Catherine Kurkowski, Alberta Today.
Hi, thanks. These are questions for the Minister. Minister, have you spoken with each of the UCP leadership candidates to receive assurance that they will bring in that repeal of Section 40.2 when the fall sitting is in session?
With all the leadership candidates about this deal, and I can tell you that they understand the importance of the deal, and they understand the importance of doctors in terms of moving forward.
Thanks, Catherine. Do you have a follow-up?
Yeah, and it seems like there has been in Alberta this cycle of, well, costs are too high, we need to get our fiscal house in order, then there's cuts, healthcare workers leave the province, and then you need to bring in these recruitment and retention incentives, and then the cycle repeats. So when we're coming up to year 4 of this agreement with the market review, the global rate review, what's going to stop this same cycle from playing out?
Well, when we take a look at our well, first of all, let me take a step back. This cycle is, that you comment on, and I don't, it may be cyclical in Alberta, but the reality is that this is a challenge that's being faced across the entire country in terms of access to healthcare workers and quite frankly, in the entire first world. So we are moving on plans to address this long-term, medium-term, and quite frankly, short-term. Long-term, as part of Budget 2022, significant investment in post-secondary institutions, particularly for healthcare workers. We need to train and grow our own. So we've made that investment through post-secondary institutions across the provinces, nursing programs, LPN programs, healthcare aid programs, and other allied health professionals. In addition, we also understand immigration is a lever that we can pull. And so we are doing that right now, as I mentioned before, success in a number of locations across the province of attracting foreign trained doctors and working with the colleges to reduce the barriers associated with assessment so they can actually get them here quicker, and not just the College of Physicians and Surgeons, but also the nursing colleges, and actually streamlining that process as that work is going on, and then leveraging those that we have. We are fortunate in the province of Alberta. So, for example, pharmacists have the the highest scope of practice, and so they can help out as part of a allied health team providing primary care to whether it be looking at prescriptions and renewing them without having to see a family doctor, and so all of this we're moving forward. So I think in terms of where we're going to be in 4 years, well, part of the work of this agreement, particularly with doctors, is how do we set up different method of pays that enable all allied health professionals to participate. How do we actually grow over the next number of years the training our own so we have more supply in all healthcare workers, and then streamline the immigration process. So I appreciate your comment in terms of you get into the cut and additional funding and cut additional funding. We need to transform our system so we get out of that cycle. Part of that is the training. And part of this agreement is also setting up a long-term planning for doctor supply, which is in this agreement, and understanding how we're going to attract and retain doctors on that. And then part of it is actually looking at transformation and different methods of pay, so we continue to hold on to doctors. And quite frankly, we need to do this for other healthcare professionals as well.
Thank you, Minister, and thank you, Dr. Warren. That is all the time we have today. If you have any other questions, please feel free to follow up with our office. Thank you very much.
Thank you.
Thank you.